I think everybody is aware that the socioeconomic disparities have really been exacerbated during this period, and most of the essential services outside of medicine are run by minority communities, which is placing them at increased risk. One thing Duke has done specifically is to partner with primary care centers and identify high-risk patients as well, and do active telephone outreach to just check in. So this is high-risk patients that in primary care centers who may or may not have any mental health issues, but just a phone call to check in periodically if they need any support. And then in the Black Psychiatric Association, there has been several outreaches to communities to explain more about the concept, because there has always been a demand for therapists, psychiatrists who understand issues in these certain communities, and this has increased over the period of time, over this period. So certainly doing active outreach is something I think should continue to happen, and I would strongly recommend.
All right, thank you. Tina, you have another question?
I do, or if it's a question or if it's a comment, I think. It's from Nkechi Conteh, and she states that as a child psychiatrist, I'm very concerned about special needs students being out of school and not having access to their needs, and foster children with many needs.
If I could just share, I have, no psychiatric expertise as a cardiologist, but I serve as a guardian ad litem, and one of the things that happens in the foster system that may not come full circle, but the supports that people get with visits and home therapies, but also really the freeze on the court system has really, I know in particular I have one case that was up for adoption. And so this indefinite hold, I spoke with a mom yesterday, and she has 4 children under 7 in her home, 2 of which have special needs. And I'm just sending her good vibes every day because that's all I've got to send her, and waiting for the idea of when court might come to pass and the services that she depends on for her children to do well, and kind of a hunker down mentality with children with special needs. Obviously you always want to be in a growth mentality, you always want to be in a building mentality, and so supporting her by text and phone has been a small thing we can do, but the logistics of individual time with children, there's just a ratio of adults to children that, is beneficial for kids with needs that is not happening at this time because of the, needed suspension in services. So like I said, I'm really curious how that gets triaged, because these are also a lot of times children that are from a health perspective at high risk to do poorly if they were to be infected. So we have to balance that need for services and their safety.
Thanks, Rachel.
The other piece of what Dr. McGinty had brought up around special needs youth and services is that there are so many youth who get speech therapy, occupational therapy, mental health therapy, or other services through the school districts. The schools, in what I've seen, have been doing a pretty excellent job in terms of meeting some of the needs around the food insecurity piece, at least, in many areas, though I know there have been challenges with that, including but not limited to that many school systems have ended up then having some of the staff involved in those programs test positive for COVID. But I haven't seen as much that appears that these youth are getting some of these other services that they need. And in talking with a lot of other child psychiatrists, I think we have a lot of concerns about what things are going to look like in September and October when people really go back to school. Obviously right now, I think May 15th is when things are listed as people going back to school, but I think most of us on the call think that that's probably unlikely, and we expect there to be extensions on that. And so given the realistic nature that it's going to be the fall when people return to school, how are we going to manage this increased need for services and difficulties that children are going to have at that time?
Well, and let me add that, we were joking before about our kids barging in, but sometimes our kids barging in is because they really need us and need us more now at a time of stress. And they know we're stressed, and they don't miss that either. So they need to know we're okay, just like our patients need to know that sometimes too. I want to point out that the North Carolina Psychiatric Association has a very good resource page And one of the things that comes to mind to plug on that is information from the National Child Traumatic Stress Network, which offers information that you can give to parents that's really very helpful about working with kids under stress and how kids at different developmental levels, different ages, will express that stress differently and have different needs for your support. So I just want to plug that toolkit because it's something you can pass along, and it was written for parents in their language. I think that's some value out of this call.
Tina, I think you've got another question for us from the chat.
I have a few comments that I think are important to mention, and there is, let me take them in order. The first one from Dr. Jerry Mattson. We are concerned in public health with if or when caregivers of children with complex conditions get sick, and who will be able to care for those, children if there is no emergency backup care. Some children might need to be hospitalized if they are on vents or other special needs. This has not happened yet. Other states are worried as well. We are also worried about respite for families where caregivers are not sick as well. Do you want me to just keep going through the comments, or do you want to address?
That's about hospitalizations, and I'm wondering if Dr. Reeder might want to comment on Dr. Mattson's comment or question there.
I think it's not just about children with special needs. It's anybody who is a caregiver that gets sick. I think that we have more and more families taking care of parents or other people in the house, and if one of those caregivers gets sick, it is a big issue. Also, we have situations where, in my situation, we have my father-in-law's with us. He's 84 years old, and so this fear of bringing home something to him, that's a real issue. And so I think that it hasn't manifested yet, I don't think, because we haven't had the numbers across the state, but I think that's going to be a real issue, is how do you make sure that someone's there to provide for family members when someone gets sick.
And if I may just add, this is another concern that trainees are experiencing, being on the front lines and having to go home to their young kids, to their family members. One thing that has come up in our early psychiatry chat line has been housing for frontline staff, and I know some states are already providing discounted or cheaper housing options for people to live closer to the hospital so that their family members are not exposed. But it's definitely been very difficult, especially if you have been exposed and you have to isolate for a number of days before you can interact with your family. So this is certainly something that trainees are experiencing in their residencies.
Yeah, I just also want to just mention what Dr. McGinty is adding. I think it was in reference to something we talked about a little bit earlier, who is mentioning a friend that this has already happened to, invited, understood, and has her at the bedside. And I think that was Dr. McGinty in reference to what Dr. Keever was talking about before, correct? I think it might be that what it was referring to. All right, I'm good. Sorry.
One of the things that this pandemic has impacted families with is just some of the sort of basic issues of a family and how family resilience plays out. And, family functioning, there's sort of 4 basic areas that we're typically looking at, sort of the membership, sort of keeping the family intact, educating and nurturing the young, taking care of vulnerable members, and providing economic support. And this disaster, its sort of prolonged nature with the social distancing and loss of jobs and people needing to be separate because of quarantine and isolation and exposure, has impacted all 4 of those things. The membership piece, the educating and nurturing of young because children are at home, taking care of vulnerable members because we can't go see our parents, we can't go see our grandparents. We're trying to sort of communicate and support them from afar. And then provision of economic support with so many people losing their jobs or having reduction in their work hours. How do you sort of maintain some of those pieces? So, as folks are looking at resilience and resilience factors, being aware of how things are currently impacting and what are some of the ways that we can support some of these functions.
Yeah. Okay.
Well, that's a great go ahead.
I was just going to say I'm going to hand it back to Franklin. So there you go.
Okay. I'm going to tag on to what Dr. Garrett just said. I have a question, and we think the surge is coming at some point. maybe it's going to be a little bit delayed. Some of the comments, Dr. Reeder kind of alluded to that. But we've got a tremendous amount of unemployment. We're going to have a lot of people that have lost their jobs and their health care benefits. There are going to be a lot of uninsured and a lot of people moving to Medicaid all across the country, especially in North Carolina. I was on a call this morning, and they're projecting perhaps 500,000 people moving over to Medicaid because of this, which suggests a big surge all across the board, whether you're an emergency room physician or in mental health. So I want to ask, how are you guys as healthcare providers kind of steeling yourselves for this impending surge? And I want to come back and ask Dr. Feldman that first off.
So yeah, we are, I think you have to do it at a few levels, with the family level of planning on me not being there as much for a while, and kind of getting things set up so that things can operate at home a little more smoothly. It's one other aspect of this is my wife she's a physician, has been basically temporarily furloughed, so that certainly impacts us economically, but also gives us the advantage that she's home a lot more to be helping to take care of the kids. From a practice standpoint, I think it's been trying to get things as up and running as smoothly as possible with the telemedicine, so that we can be efficient with that and not, try to work through some of these technical difficulties and, kind of have a game plan in place. If we get cut off, we go right to phone. So we're not having to figure it out on the fly as much. And I think that we've been sort of figuring that out the last couple of weeks, so we'll be in a better place, as we're expecting things to be picking up here in these next few weeks.
Okay. I'd like to hear from Dr. Reeder again, please, on that same question, Dr. Reeder.
Yeah, we were anticipating the surge, so we sort of upstaffed. We actually had a call this morning where we said it hasn't come yet. So we're actually going to try to pull back some of our coverage on an almost day-to-day basis to say, you're on the schedule, but we're going to tell you not to come in until we call you. So we're not physically going to be there. There's still that anxiety of, am I going to get the call? But trying to prepare ourselves for that inevitability. And in some of the challenges that the predictions are wildly divergent. On one hand, we say we're going to have 500 ventilated patients in the ED or in the hospital, and we only have 400 ventilators, and there's only going to be 150. And so trying to anticipate that is really sort of the challenge. I think the other thing that I worry about is that there's going to be this huge pent-up demand at some point. And there's going to be a huge pressure to start doing all the elective or semi-elective procedures, which still revenues for hospitals and for physicians. And that pressure is going to happen at the same time that we relax all these other restrictions. And I worry about bringing all of that back into a stressed health system. And from a hospital system and from a physician practice, those people who aren't working, who aren't generating the revenue, there's going to be huge pressures to do that. But then we're going to have all the chronic conditions that haven't been met for the last 6-8 weeks who are also going to be competing for that. And so I worry that is just going to overwhelm us in a bad way.
Thank you. Dr. Keever, are you still with us? I would like to hear from you.
I am, and
Okay.
I think the beauty of being wrong once means you're more willing to accept that you might be wrong again. And so as we're trying to sort of time our peak, one of the things that's really, I put in the chat box is that nationally, the American College of Cardiology has very robust data sets, almost on hour-to-hour acute myocardial infarction event rates. And we are seeing literally across the nation 1,000 less heart attack patients coming in. And that actually also expands even into the ST elevation myocardial infarctions, the things that we all think of as random events that are just going to happen, and surely patients come in no matter what. So our cath lab is sitting empty. In fact, we had to send out an email yesterday basically saying that if you have an emergency, a case in the middle of the day, be sure you call because there might not be anybody in the cath lab. And to contrast that to what we've been doing, which is working till 9 o'clock at night and doing elective cases on Saturday and Sunday, it's like a different planet. Our planning and our ability to prepare and staff and train and, financially understand what we need to do next is incredibly difficult. And we have just gone through a large corporate buyout in the last year. And so we're just starting to get our footing on what that looks like. From a, just from an operational standpoint, not even really from a fiscal standpoint, but just how do we staff a really busy cath lab? And then we're sitting in a cath lab where we know people with heart attacks are not coming in. Do we think that pent-up demand is going to actually bring us towards, a disaster day where we can't keep up? Or do we really think that those events will just go in the background and present as chronic disease and heart failure later on? I think the answer is we really don't know, that we need to kind of think about both scenarios at the same time. But fiscally, we're not really going to be able to turn it back on at the same pace that we had it before because we've let go of the resources that allowed us to run at that pace.
Well, and let me ask you this, both in terms of what you were saying, Dr. Keever, and what Zach was saying. A lot of us are in corporate situations or huge health systems where we don't necessarily control the resources. We don't necessarily direct the workload or decide when the door is open or when it closes. And I wonder how relations are going with administration, if administrators are reaching out to the providers and really planning this together, if the information is at least flowing back and forward in these larger organizations, because I imagine if it's not, that would add a whole other level to what people are dealing with now.
That's true, and I think we have a sort of a legacy relationship with our chief medical officer, who's been very physician open and transparent and letting us know where we are. I think the reality, though, is, for example, in order to qualify for pandemic pay, we actually had to agree to be able to deploy not just to any hospital within the mission system, but actually be deployed to any hospital within the national HCA system. And, for people with kids and like for me with another, corporate responsibility, it's very hard to imagine me just agreeing to be able to float anywhere in the country. If I was choosing to go to an area where I wanted to give pandemic care, that would be very different. So the idea that you're just being flexed for corporate efficiency is not a concept that most of us have really thought about. We think of ourselves as tied to communities when we give care. So it's definitely stretching our idea of corporate physician employment.
I imagine so. Just as I've worked in VA central office in Washington, and to us that's a wonderful dream that we can move our assets from here to there, and boy, we can meet a need. But the real key is in coordinating that with the actual people who might be moving, and knowing what the criteria was for who's truly movable and who's not. And frankly, I think, as a lot of people are waiting, is there going to be a surge? What's happening next? To be thinking about how do you negotiate this with your leadership? How do physicians band together and talk about what's doable, what's not doable, and communicate that now before you get that call. Hey, you're going to Milwaukee, pack a bag.
Okay, we've got time probably to go on a round robin, and I've been holding this question out. We talked about a little bit of stress from you guys as providers. How do you see your staff in terms of their stress level now? What are you doing to help them through that, both short-term and long-term? And Dr. Conteh, you have not answered the question a bit, so let me come back to you.
Oh, well, thank you. Certainly, I think this ties in together with the previous conversation we just had about what we're doing to prepare for the surge. We are also extending that to staff and other healthcare workers. We are undergoing a lot of disaster training right now. We're doing psychological first aid. We're also prepping, even as psychiatry residents, we're getting ready for the possibility of being deployed to the ICU in case the surge happens. So we're doing some online trainings for that. And we are organizing and providing support systems for staff, huddles. We're having Zoom conference calls. Virtual yoga is something that we discovered recently. So tips and ways for healthcare workers, staff, residents to de-stress and decompress and handle their emotions when certainly there's so much uncertainty going on. So there's been a lot of work on videos and webinars and Zoom calls to help build resilience and promote self-care amongst healthcare workers here.
Dr. Feldman? Go ahead, sorry.
So I think that a big thing for us has been really trying to give all of our staff a sense of mission in really not only keeping our practice going, but we're helping with the health of our whole community by doing our part. Another thing that goes back to the, I started doing the psychological first aid training myself, and one of the things that it talks about is offering food and water to people and kind of basic needs. And one thing is bringing in food for the staff and things like that, that just show your appreciation and also just kind of help give them a little boost. And I remember being, when I was a resident, certainly, that would, I had a attending that would bring muffins, things like that a lot. And I remember just that the amazing difference that made in your day.
President, I know we have a comment. We have a comment from Dr. Edwards. So I'm just gonna.
Thanks, Tina. I just wanted to kind of back up to something that that Tim and Rachel were talking about. That's just important to mention. Is that often this kind of speaking with a medical society hat on? Is that often or not uncommonly we don't agree necessarily with the hospital association on different issues, but there've been two kind of neat examples the last couple of weeks where that's really shifted. One of those is that, as some of you may know, is that the Medical Society and Hospital Association, Institute of Medicine, and other groups have come together to create a scarce resource allocation protocol. This is kind of dusted off of the one that was developed in 2010. And I know that Melanie Phelps is on the call and may have to speak to this as well. But we had kind of an active, good conversation with the Hospital Association, now called the Healthcare Association, about this. And I think we were all in kind of like mind trying to come up with a rational approach to how scarce resources be allocated, specifically ventilators. And that message or that proposal, many of these groups I just mentioned was sent on to Secretary Cohen. And then the other one that's I think important to mention now is that there are ongoing conversations. I spoke with Medical Society CEO this morning about an idea that came up a few days ago about could hospitals help sterilize PPE that are used in doctors' offices, to use the hospital machinery or their sterilization equipment so that practices could have their PPE kind of up and running the next day. So that's kind of being discussed. But so there's kind of this unusual vibe of we're working together, how can we help the people in North Carolina, which sometimes is not always the way it feels in our relationship with the Healthcare Association, but it is right now. So it's nice to see that coming together. That's all I need to say. Thanks.
Thank you, Dr. Edwards. I want to get back to two other physicians. Dr. Garrett, how are you addressing your staff stress, and what are you thinking about all that?
Well, so, I think there's a couple of things, and one of the most important is identifying that this is going to be a marathon, not a sprint. I think at the beginning, we were all just trying to sort of scramble to figure this out. And actually, as someone on one of my calls earlier today said, that this is actually not even a marathon, but it's an Ironman race. So this is going to be an ongoing thing. And in some of the discussions I've had with some of the Duke residents and others, I've talked with them and with other folks about doing a self-assessment to really determine where you are. What are some of the things that are your areas of concerns or your strengths? How do any of your personal or professional commitments impact your ability to respond and impact your resilience? So like Dr. Kiever was saying, she may or may not be able to respond to something that's here versus something halfway across the country. Also being conscious as you're identifying what you're able to do and not do, if you have any physical or mental health conditions that would impact your responses. Where are you in terms of any recent personal prior trauma exposure or recent losses and grief, and how might that impact your ability to do some of the work you're being asked to step up to? And then also being aware of where you lean on the sort of balance of compassion fatigue and secondary traumatic stress versus resilience and traumatic growth, and identifying what are some of the things that you're able or willing to do to improve your situation, with the awareness that for many folks, their traditional sort of coping strategies may be not accessible to them with social distancing and with some of the lack of social contact. So how can you identify what are the things that you are still able to do that are going to kind of help you to decompress and kind of separate from the work as well?
Okay, thank you. Well, we're just about out of time, folks, so I want to thank everybody that participated in the call today for calling in. I know these are crazy times, but we loved hearing from you guys. I want to remind you that we have a lot of resources on the North Carolina Medical Society webpage that are COVID-19 related, about telehealth, about mental health, and so I would say if you need some resources, go there. And so now I'm going to hand it back to Tina.
Well, I can only thank you all so much. Thank you all to our guests, to our guest moderator, to everybody who took part in this session. I hope you will be able to join us next week again. We're going to go and have a session on emergency medicine. We welcome your comments. We welcome your feedback as well. We are in this together, and we can only get better and learn as we go along with this. So thank you so much, and I hope you all stay safe and just know how grateful we are for everything that you do for us out there. Thank you so much.